Our connection this hour was made with a diagnosis of cancer, prostate cancer that has metastasized to the bone. We don't know exactly when President Joe Biden learned that he has cancer. The news prompted all kinds of speculation and allegations even this spring. Doctors have told us on this program that it is possible that the president could have been given a kind of a clean physical a year ago and then have this diagnosis a year later. That happens. But apart from the questions about the president's health, there are separate questions about how this kind of information gets communicated. And I'm not talking about with the public. Most of these cases are not public people. I'm talking about how a person with a diagnosis of cancer, metastasized cancer, might tell their children, their family, their friends, and how they confront that information themselves. At the Wilmot Cancer Institute, investigators have enrolled 300 local and regional individuals all over the age of 65, all of them with advanced cancer. The investigators are studying the impact of social networks and support after a cancer diagnosis. Beyond the obvious, there are important questions about whether a person with cancer will continue with treatment and why. There are questions about who influences their decision-making and their quality of life going forward. Here's how Wilmot describes this study. Quote, "Many people have social networks they cherish, family and friends, a church community, book clubs, sports leagues, colleagues at work, and online groups. What happens with these networks when a person gets cancer? We know that most people don't just go and do whatever the doctor tells them," Dr. Supriya Mohile said. "First, they're likely going to talk to people, maybe a spouse, a sister, a neighbor, and whether their information is right or wrong, technically and medically, it goes into every decision," end quote. So this is a conversation this hour that really touches everybody, just about every household, every family. How do you receive information? Have you had good or bad experiences in that kind of a setting? Do you feel like the information was communicated to you gently but accurately, with enough information for you to decide? Do you have your social networks change with this kind of a diagnosis? Maybe you know someone working through cancer right now, and I want to just tell the audience we're going to try to be as sensitive and as kind as we can about these very difficult questions, and we invite your feedback. If you want to share that with us, connections@wxxi.org is the email address, connections@wxxi.org. Maybe you've had a good experience. Maybe it has helped inform what you do or someone you love. Maybe it hasn't gone well. Maybe you've changed how the people you trust and how you decide, what kind of treatments. If you want to call the program, it's toll free. It's 844-295-TALK, 844-295-8255. 263-WXXI if you call from Rochester, 263-9994. If you're watching on the WXXI News YouTube channel, you can join the chat there. Let me welcome our guests in studio. Dr. Ronald Epstein is professor of family medicine, oncology, medicine, and palliative care at the University of Rochester Medical Center. He's the author of Attending: Medicine, Mindfulness, and Humanity. Welcome back to the program. Nice to have you.
Great to be back with you.
Great to have Dr. Supriya Mohile with us as well, a geriatric oncologist, professor in the departments of medicine, hematology and oncology, surgery, cancer control, and the Cancer Center, and vice chair for academic affairs in the Department of Medicine at the University of Rochester Medical Center. Thank you for being with us.
I'm very happy to be here.
And welcome to Abby Squicciarini, who is an oncology social work supervisor at the Lipson Cancer Institute. Thank you for being with us as well.
Thanks. It's great to be here.
So let me just kind of start with a broad question for all of you. And Dr. Epstein, maybe you're the person to start this off, because when we talked 8 years, I was asking, when did the book come out? 2017. It's amazing what happens to time. Time is relentless, but the book was so good and so powerful, and I have no doubt that many of your colleagues have read it. Is it your assessment almost a decade later after you wrote Attending that the bedside manner, that the way information is communicated is better? I hate to be kind of squishy and nebulous there, but is it better now?
It's kind of a mixed answer. I think that doctors in general are more sensitized to communication and understanding that patients are people first and patients second, that they have social networks. On the other side, I think time has become more precious, that visits in many settings have been more compressed, so it makes those conversations more challenging.
Dr. Mohile, what have you seen?
I agree with Ron. I really think that in medical school and residency and fellowship, clinicians are being trained. Social work, Abby's here, I'm so glad. We're all being trained to communicate more effectively with patients. But I agree also with Ron that the time is precious, and we have to do it in a more quick way that may not be amenable to all patients, because we have people waiting in the room. So for us, it's challenging too, but we have to, as Ron said, put the patient first always.
And collaborative care is what that is about. Tell us a little bit about how that works, Abby.
Yeah, so at Lipson, we have a program. It's called Collaborative Care. It's an in-house therapy program where we work with patients to address symptoms of depression or anxiety. We can work with patients speaking with their family if they got a diagnosis, if they are entering survivorship, if they relapsed. So we can really develop coping skills and mechanisms to have those conversations and help facilitate those conversations and make sure that they feel supported. So we have our collaborative care program, and then we have medical social works where the physicians, APPs, can really tap into in the moment in those tough conversations in clinic and have those conversations with the patients and then also their loved ones.
I was going back and reading, we're going to talk about some of the Wilmot study coming up here, but reading some of what Dr. Epstein has said over the years, went back to a 2013 story, so way before the book here. But you were raising a question about our personality types, and some personality types are very technical. So some people, when they receive information, they want it to be technical. They want it to be very detailed, specific. Okay, I've got a cancer diagnosis. What does this mean? What stage is it? What does that mean? Tell me about treatments and timelines. Tell me about side effects. And some need a very different kind of approach, not technical, but much more compassionate. Conversely, some professionals are very technical in how they want to deliver information. They think everybody needs the information, I'm going to provide it, and then they can make the best decisions. Others are, I think, a little bit more like Dr. Epstein and probably a little bit more on that compassionate side. Can you learn to cross over? I mean, like, do you see people who have been in that technical world bringing a different approach, through effort? Can we kind of change, or not change our personalities, but learn different ways?
I think so. I mean, one clear example is if the doctor themselves has had an illness experience in themselves or a family member. So really understanding what it's like to be a patient. And I also think that it has to do with the institutional culture. Is there really a culture of communication within the environment, with your colleagues, with other people? And I really think that, at least here locally, that has changed, that people not only talk about the technical aspects of illness, but also how patients are coping, how they're adjusting, what they can do to foster greater understanding. So I do think there's been a culture change.
What do you say to a colleague who argues, look, I'm going to provide the technical information because they will then take that and respond however it is appropriate for them. It is not my job. I'm not a licensed counselor. I'm providing technical information about, in this case, perhaps a cancer diagnosis. What do you say to that?
There's a way to do it effectively, which is to give the information in small bites. Some research that I've done since we last met showed that physicians who tend to lecture, who speak in long paragraphs and have information-loaded conversations, their patients at the end of the visit actually understand their illness less well than if they get the information in small bites. And the doctor goes back and checks understanding, saying something like, I just gave you a lot of information. Tell me when you go home what you're going to tell your family about what I said. Or tell me, just why don't you tell me back what you're taking away from this conversation?
And then often you can uncover if there's misunderstandings.
Exactly. And with some things like prognosis, for example, the misunderstanding level is quite high. That is, doctor's assessment of the seriousness of an illness and patient's assessment is often miles apart.
Yeah, my stepfather passed away last September, and my mother is the type of person who needed that soft touch. Now, she needed good information, but she was kind of pre-grieving, really struggling. I am the type who I want these specific details so I can understand it, so I can help, sometimes it's help plan, sometimes it's help make decisions on what certain things mean. I've mentioned before my stepfather's passing, we kind of thought he was indestructible. I mean, he died at 91. He had everything, I think actually everything. And we thought for a while he might be indestructible. And, so he had a good long life and we miss him. But, there was a time when he was 85 when he said he had a different type of cancer. I don't want chemo. Mm-hmm. I don't want to even talk about that. Started radiation and stopped halfway through. Mm-hmm. And said, it's terrible on him. And there are other family members like, no, he needs this. He needs this. And he's going, I don't want to do this. There's a limit to what I want at my age. So he was firm about that. But my mother needed something soft. And, that information hit her like a sledgehammer every time she was worried about losing him. I wanted the details, technical side. Mm-hmm. Isn't it part of the responsibility of your all world to kind of assess what you try to find out what people need before you kind of go in with an approach? I mean, it's not easy to do, but it's important, right?
Yeah, no, I can resonate with that because I've dealt with cancer diagnoses in both my parents. And so I've been on the receiving end of this. A simple question like, what information would be most helpful to you right now? If I ask that of a patient, usually they can answer. They can say, well, am I going to live or die? Or what percentage of people tend to progress with this illness or relapse? So, it's a good starting point. And then, provide a bit of information and say, okay, just make sure that we're still on the same page and then move on. So I think that, and I think clinicians, it's incumbent on us to be adept in both of those domains, in the kind of the soft touch, what you call, and also giving to the degree that we know facts. And just want to add something is facts in medical research is about groups of people. So of all patients with stage 4 lung cancer, the average survival is such and such, but we can't say exactly how long you will survive.
Right.
And so, conveying that the two sides of what we know and what we can't possibly know is also, I think, a skill that can be developed.
We all should have taken statistics growing up. We're not great. We're not great with numbers as people. Dr. Mohile, how do you kind of work through trying to make sure you understand what people want or might need in a hard moment? It's really concerning when your colleague says there are settings where people actually leave the room more confused or poorly informed about a diagnosis. That's a problem. So how do you deal with that?
Yeah, I think it's a real challenge. And at first I want to bring up what you said, Evan, and I'm so sorry about your stepfather and what you went through as a family. We see this every day in the oncology clinic. So as a geriatric oncologist, most of my patients are in their 80s and their 90s. And as Ron said, data is really from groups of people, but when people get older, there is limited data on what's safe and effective for those groups of people because older adults are not accrued to clinical trials as often as younger adults. And at Wilmot, we have this big focus on trying to enroll older adults to really get the answers that families need. So the first step is, is there an answer? Is there evidence that shows us that that treatment is safe and effective for the person sitting in front of us? We always have to do that first in oncology. And then we have to really be honest when there's not. So this is the uncertainty. If I take a clinical trial or look at the guidelines and I know an 85-year-old has other medical problems, then I have to be honest and say we don't have data for someone like you because we just don't. And so in the end, what I tell older adults is that you're in charge. This is your decision. You make the decision here. I'm going to give you all the different options, and then you are in charge of your decision. And for older adults, that's really important because they do rely on social networks. They rely on their children. They rely on their spouses. And then we take a step back and say, where is the social network in this conversation? Because it is a family, friend, network decision. And I think when people, as you mentioned, take away misinformation, it's because everyone hears something different in the room. And, you can have someone hear one thing and another thing. I mean, I go to the doctor with my parents and my siblings are all doctors and we all hear things differently. And so you really want to make sure everyone has a shared understanding. And this is from Ron's work, honestly, this sort of idea of shared understanding. Where are we here? Here's the plan. What does everyone want to, how is everyone thinking about this and how are we going to move forward? And then you develop a relationship over time so that you can communicate effectively about more difficult things that will come up for somebody with advanced cancer. But patient preferences, especially for older adults, guide the next steps, always should guide the next steps, even if it doesn't match what the papers show or what the guidelines show.
Kristen Brockport, I'm going to take your call in just a second. Abby Squicciarini, can I ask you to weigh in on this as well here? How do you help people who may be struggling to process or have bigger questions and don't feel maybe like they're equipped to kind of either make decisions or handle it mentally?
Yeah, so we can do that in a couple of different ways. I think the best thing in the medical setting now, and especially in oncology, is it's not all on the providers. It's an interdisciplinary team. So you're having a social worker there to be able to say, maybe there's a little bit too much medical jargon going on here. This patient doesn't seem to be understanding this. Let's reframe it. Let's meet again. We do distress surveys with all new diagnosed patients. And what happens is then they're referred to the social work team, and we can give them a call either the next day or a couple days after that initial appointment to check in and say, do you understand what your appointment was about? Do you need clarification on anything? If they're really struggling mentally, then we can connect them with our in-house therapy program. If they're lacking a social network, if they really are looking for more support, we can get them connected in the community with support groups or internal support groups. So I think the biggest takeaway is having this internal interdisciplinary team to be able to look at the patient as a whole and just keep revisiting, what do you know, what do you need? And
how often when you follow up do you find that they don't have a great picture, or they might have some things wrong?
Yeah. Unfortunately, a lot, that initial appointment, some patients are just in shock. They're not really taking everything in, and sometimes the social workers, we just have to send a message to the providers and just say, I think this patient would either need another follow-up appointment or just a phone call to clarify certain things.
Boy, that would have been huge in our family. My family's in Ohio. My mother, was in shock getting some of these for her husband, these diagnoses. So she would bring her sister, my aunt, who, I love you, Aunt Sue. You are the worst at understand. It's like a game of bad telephone. She would call us, and I'm going, well, what you just said doesn't exist, or this does not make sense. So that follow-up phone call is so important. I'm really glad you do that. I love you, Aunt Sue. Just don't want you trying to share that information. Chris in Brockport. Hey, Chris, go ahead.
Hi.
Yeah, go ahead, Chris.
I just wanted to share that in the modern age, I received my diagnosis in a way that I wouldn't have expected. In 2018, I received my diagnosis through MyChart, meaning an email notification. I go right into MyChart, and there I am. I'm reading it. And it was shocking. I did, of course, have a follow-up appointment a week or two later, but in between that reading MyChart and then the follow-up was all sorts of anxieties I can't even describe.
Can I ask a little bit about your experience, Chris?
Yeah, sure.
I mean, how do you characterize this now, having learned it that way?
It was shocking. I didn't feel, I wish after the fact that it had somehow been withheld on my record and the doctor had delivered that information. But that's not how MyChart works. As soon as you get a test result, it's coming to you.
Yeah. And, there are times MyChart is really helpful. I mean, I used it, of course. So I can understand the desire to share information quickly, but it sounds like what you're saying is, maybe if it's like that one, maybe don't send a bomb on MyChart. Is that kind of what? Yeah.
Yeah.
Okay. How are you doing now, Chris?
Doing great. That was how many years ago? That was 8 years ago. So I received I don't know exactly what you would call it, a biology type treatment where they injected tuberculosis into my bladder to take care of the problem for I think over a course of 6 months. Since then, all of my rechecks have been clear, so I feel lucky.
Well, here's to more of that, Chris. Good luck to you. Thank you for sharing your experience with us. Really appreciate that phone call. And Chris is one of millions of people on MyChart. I mean, there's times where it's like, oh, we got to get a MyChart on this. But go ahead.
Yeah, thank you, Chris, for sharing your story. I think this is happening very frequently now. And it was interesting when we went through this transition to electronic medical record. At first, much of the information was not released openly. And then there was this motion, and it may be a legal thing, I don't know for sure, but motion that patients have a right to their information as soon as it's available. And as oncologists, I know our team at Wilmot was worried about this, about patients getting their diagnosis in the way that you did. But I don't think that we could change the process or procedures. And it does happen this way quite frequently, unfortunately. And I can't even imagine how you felt during that week. What I try to do in clinic is to make sure that those tests are done right before I have an appointment scheduled. I never leave it open so that I can answer questions and provide information in real time. And we always welcome people calling us or MyChart, using MyChart to reach out and say, I just got this news, what does it mean? And not have to wait that week of torture of just wondering what's going on. So we do encourage patients and families to reach out to their doctors when this happens, but it isn't something that we have control over either. It's just the system, and I don't know that it can be changed. But when it was transitioning, I was in that transition period, and I was personally very worried about this too. I wouldn't want my diagnosis that way if I were diagnosed with cancer.
Dr. Epstein, what do you think?
There are ways of preparing people. When you do a kind of high stakes test, just to say, I'm really hoping this shows that it's something that's, really benign, that it's easily treatable. But I think we also have to be prepared for news that might be more difficult than that. How do you want to hear the news? You may get a MyChart alert. It's up to you whether you actually do click on that. And also just indicate availability as Supriya does. But I think there is some, I like to put the locus of control back with the patient. And I could easily imagine myself having a test and deciding that, no, I am not going to click and open MyChart. I'm going to wait to see, whatever it is, a day or a week to see somebody.
Yeah.
And
what do you think here, Abby?
I agree with Dr. Epstein. I think the internet is a great thing, but it can be pretty dangerous, especially in the oncology world. Opening your test results and then deep diving on the internet can really be detrimental to anxiety and depression. So, maybe holding off on clicking those results. I think it's great that patients have access to all of their charts, but it can cause some issues like this, which is really unfortunate. But if something does come up, if you see a result, call. Social work is available to everybody if you need some mental health support while you're waiting for that appointment. Or our doctors are pretty receptive and can jump on a phone call if it's really necessary.
Yeah, and Chris, I just want to offer a little solidarity. I mean, I understand, first of all, the desire to get information quickly, and I also, having had a lot of experience with loved ones who have had different types of cancer. And there's different things that you would see in a MyChart where you go, I think this means this, but I'm not totally sure. What is DCIS? What does this mean? Is that exactly cancer? Is it not? And that can be really tough if you don't know when a medical professional is available to answer those questions. That's why I like Dr. Epstein's point. Here's my availability. You may be getting a notice. If you want to click on it, it's up to you. Here's when I'm going to be available to talk about it. And if it's overwhelming for you, good or bad or otherwise, hang on until we can talk. That's a great idea. It's tough because a lot of people want the information immediately. But boy, it's not always just cancer, no cancer, good, bad. It's a lot of technical stuff. So I can really relate to what you're saying there, Chris, and we wish you well. Let me get an email from Andy who wants to know if the guests, what do the guests think about the recent debate about MAID, medical aid in dying. Dr. Epstein, I think it just passed the state Senate this week. It passed the New York State Assembly at the end of April. It awaits a governor's signature. It is billed as a form of MAID, medical aid in dying, that is much more narrow in scope than what you see in perhaps, say, Canada, which has broadened over the years. Anything you want to add to that? Andy's asking what our guests think about that.
Other states in the country have had a long experience with that, and it's generally been positive. Philosophically, I believe that people should have a right to control what happens to them, and especially when faced with a serious illness and a very limited prognosis, to choose how and when they want to die. I do think people have that right. Early concerns about abuse, for example, of people agreeing to medical assistance in dying without consent or being coerced don't seem to have materialized, at least in the research in this country. In fact, there's a sense that the opposite may be happening, that that people who really do want to access it for various reasons don't have access or are talked out of it by family members, social networks, what have you. It also prevents a lot of people from taking these matters into their own hands. That is, trying to procure drugs, trying to end their own life without medical assistance. I've been, as a palliative care doctor, I've encountered situations like that, which have often been quite disastrous. So it really does prevent that.
Dr. Mohile.
Yeah, I agree with Dr. Epstein. I will say, even a step before that, part of serious illness conversations is asking patients about their future and how they would want their future to be when they are faced with a terminal illness. And, we have advanced care planning programs where, and that's part of our conversations at the right time and the place. I personally feel that all patients have a right to make those decisions themselves. And for that, it's what we call do not resuscitate or do not intubate, especially there's other things that we could do too. But if your heart were to stop and you were to stop breathing, would you want resuscitation? Would you want to be on a machine? That's really important for someone who has a terminal illness, because in many circumstances for people who are more frail or getting treatment, those are very difficult things to go through. And it may, even if one survives, their quality of life can be very poor in a way that they can't envision, really needing a lot of care or being in a nursing home, et cetera. So we have those conversations already that need to happen at the beginning. In terms of this new legislation that might get passed, it has to be operationalized in a way that makes sense. So it has to be done in a thoughtful way with people that really know, like Dr. Epstein or other palliative care doctors who really know how to have these conversations, who are really figuring out what is if a patient is doing this in a way that they're really understanding what they're doing and what decisions they're making versus being severely depressed or having other kinds of things going on, delirium, confusion, and then also working with the families too. And we'll have to see how that works. As Dr. Epstein said, it's happening in other states, and I do think we see a lot of people that suffer, and there are some patients who are suffering so much that this is maybe the right thing for them if they choose to do it.
And I just want to point out, separate to MAID, you have said, Dr. Mohile, that you find that about 40% of patients decide to do additional cancer treatment only because family wants them to press on.
Yes.
You said you hear that in your clinic all the time, which again is part of the decision-making process. It's part of that network. But it's interesting because that sort of lines up with some of what Dr. Epstein is saying, that even when MAID is available, there's a lot of pressure from people around people not to use them to extend their lives. So it's complicated. It's a very complicated.
And I think as we think about patients and people coming to the doctor, as you said, it's not just one person. It is a network. We, as in the clinical setting, we only have a brief snapshot of time with people. Maybe it's 15 minutes, maybe it's 30 minutes, maybe it's 45 minutes. But people have lived experience that drives their preferences. And then they have networks that drive their preferences. And, they may listen to people in their networks who they have very close relationships to over their healthcare providers because they trust those people and they want to do what they want to make sure that those people are okay. And that's what we see often in older adults, that they may say, look, I'm 85. I've lived a great life. I really don't want chemotherapy like your stepfather said.
Right.
But I think, and it may not even be open conversation. It's implicit. I don't want to disappoint my family. I know they want me to do something, and they just do it because of that. And that's what having serious illness conversations is all about, that we are asking about those expectations, not just from the patient, but from the whole network. So it becomes open, and that we're moderating that with the help of our social work colleagues who are excellent at this, and palliative care colleagues who are excellent at this, and that people have support to do that. As an oncologist, I rely my colleagues to help too, because it can be very emotionally charged and difficult. And so as a team, we're providing that to the whole family, not just the patient.
Abby, what would you say to Andy, who wants to know more about medical aid in dying?
Yeah, I can't speak to the medical side of things, but in the social work field in oncology, we definitely work with patients a lot who maybe express suicidal ideation that might be just based on their circumstances, their symptoms, their diagnosis. And so I think it's a great tool that we have our therapy program. We can sit with the patients bi-weekly. We can do it over the phone, by video, or in person right after treatment, and really develop a rapport and a relationship to figure out what are some things we can fix, and then also have those conversations. What if they're terminal, if they're towards end of life, what does that look like for you? What are some things that are important to you? So I think it'd be something great, but it would have to be a team effort conversation to make sure the patient is fully aware of the decision they're making. There's no outside forces. And to be safe about it.
I'm heartened to hear that Dr. Epstein says the research indicates that concerns about abuse, and understandable ones, we've heard from folks in the disability community who are worried about abuse, but that is something that is on the radar of people in the medical profession, that you're concerned about that. But there's also research that indicates, at least from what I'm hearing from you, that that there is not regular abuse happening with medical aid in dying where it is available.
Yeah, as far as I know. Yeah,
Okay.
and at least in this country and Canada, and most of the data that's coming out of Europe as well, even though their MAID laws are actually more expansive than the U.S. And
So after we take our only break, we're going to come back. We're going to talk a little bit more about the study that's going on at Wilmot, and we want to talk about when you get a diagnosis, a very serious one. We talk a lot about cancer. It's not always cancer, but when you get a very serious diagnosis, who do you rely on? What is your social and close network? Does it shrink? Does it broaden? And how do you make decisions? What kind of information do you want provided to you? What do you expect from the medical community? Who can you collaborate with? Who is there for you? So we're going to talk about what's going on at Wilmot with the study, and we're going to share more of your experience. We're going to come back with our guests who are in studio, Dr. Ronald Epstein, who is the author of Attending, Medicine, Mindfulness, and Humanity, and a professor of family medicine, oncology, medicine, and palliative care at the University of Rochester Medical Center. Dr. Supriya Mohile, a geriatric oncologist, and a professor in the departments of medicine, hematology, oncology, surgery, cancer control, and the Cancer Center, and vice chair for academic affairs in the Department of Medicine at URMC. Abby Squicciarini is with us, who's an oncology social work supervisor at the Lipson Cancer Institute. We're right back on Connections.
Supporting your favorite programs on WXXI TV and radio is just a click away when you go public at WXXI.org. It's a convenient and secure way of supporting an important community resource. WXXI.org. Go public and pledge your support today.
This is Connections. I'm Evan Dawson. Janine writes in to say, I'm surprised to hear that people are pressuring patients to continue their lives. If they are deciding that they don't want more types of treatment, it is up to them and them alone. Thank you, Janine. I appreciate that comment. And that's probably related to what we said earlier when we talked about some of the studies that are going on about your network, who's around you, who's going to help you make decisions, who are you going to consult with if you get a serious diagnosis, cancer or otherwise. Janine is saying, don't let people talk you into doing any treatment that you do or don't want. And I'm going to start with Dr. Mohile. So why don't you tell us a little bit about, first of all, if you want to respond to Janine, I'll give you some space. And then tell us about what Wilmot is studying and how you're doing this.
Thank you, Janine. I totally agree with you. It is an individual decision about, people are in charge of their own bodies. They should decide for themselves what treatments they wish or don't wish to receive. Having said that, there are a lot of people in this world who care a lot about their families and friends and want to incorporate their decisions and, their opinions into what they do, and may change their gut feeling in order overtly or not overtly, it's even sometimes implicit. They have a feeling that their family wants them to do this. It might not even be a conversation, but they do it because they're worried that they're disappointing their family or letting them down. So that happens in the clinic quite a bit. And as I said, it's really takes some open communication. It's this kind of example or this kind of situation that led to us researching social networks in older adults with advanced cancer. What advanced cancer means, it's cancer that's incurable, and there's no treatments available that will get rid of the cancer. And so we're giving treatments that we call our palliative, that they are designed to help people live longer in the best case scenario, but at least help people get lower symptoms and better quality of life. And there are sometimes what we call narrow therapeutic index, that sometimes the risks outweigh the benefits, but we don't know for sure until a patient tries it. And so it becomes an individual decision of the patients if they get the right information, if they choose to go down that route. And we found that, sometimes when we're talking to patients and we're thinking about things, we get a sense that the patients may not have all the information, and then they come back with a decision, and all this stuff is happening outside of the clinic, and we're not always sure about how people came to that decision. So Dr. Epstein, myself, and our third MPI is Dr. Reza Yousefi Narai, who's a social network expert, decided to use tools like social network analysis, where we're learning deeply about who people trust in their social support network and looking to see if we can see trends and patterns in how people make decisions as they move forward with their care. So it's an observational study. We're recruiting from all over the Rochester catchment area at Wilmot Cancer Institute and all of our affiliated clinics. And we're really observing how patients make decisions with their social networks.
Related to that is a question from Maggie, who's on the phone, about how you're doing things. So Maggie, in Rochester, go ahead.
Hi. So first of all, I'm really glad to hear about this. My father was diagnosed with stage 3 lung cancer about 12 years ago. And we really struggled. I think the idea of like a family involvement would have helped us tremendously, because I think what you're pointing to is the fact that people with complicated lives, and my father had a history of drug and alcohol abuse, and he also had a history of sort of like violent behavior. And so what ended up happening was that he was being given palliative care medication that he was managing poorly, and he ended up a danger to himself and others. And we had to forge the lines of communication with his palliative care team and with his doctors to try to figure out a balance for him between managing his pain and endangering himself and all of us. And so it was really difficult, and we had to seek those connections 12 years ago. And so I'm curious about how all of this is happening and how you are involving families for so that, people don't have to go through the same thing, I guess. Thank you.
Maggie, it sounds like you were a little in the dark 12 years ago.
Yeah. And I think that he would have received better care if there had been an effort to talk to us, and we could have said, my father is not a person who can manage being sent home with a month's worth of Dilaudid at a time. That's just not realistic for him given his history. My father is, people have various history. My father is a person that has complicated relationships with his family that are characterized by a lot of trauma, like both for him and from him, right? So when we deal with his care and his behavior, these are the reasons. There were times when he was being really erratic that we would kind of step back, and then the reception that we got from his doctors was that we didn't care, right? Or that we were like cold to him. When we loved him very much, it's just that he was a violent and volatile person, and so we had to do things in ways that were safe for us. And so it was just, I think, not only would our ability to advocate for him better, but his care would have been better if we had been invited to the table from the outset. Does that make sense?
Yeah, absolutely. Yeah. And Maggie, much love to you. I'm sorry about what you went through, and I think there's a lot here that all of our guests, can kind of talk about. Let me start with Dr. Mohile, because I think it does relate to what they're studying. But the first question that Maggie has is, has the policy, or when did the policy change of involving more family in communication? So has that changed over the years?
I'm not sure if there's a policy, but
Okay.
I think as we've learned more about communication and have utilized the research that, Dr. Epstein and others have developed, is that we do really have to think about everyone in that network. And as a geriatric oncologist, and I'm so sorry you went through this, we see very complex patients. And I always think about, this is the lived experience of people, and the relationships can get more strained when someone's diagnosed with cancer. It sort of accentuates all of the issues that may have been there for a long time. And you can't judge families in difficult situations because it's hard. People have these relationships for so long, and they're going to continue when someone has cancer. And so, what I think our research will help with over time is developing what we call social network interventions. In good communication, we should be eliciting input from care partners and social networks in the care of individuals. And we do this as part of our geriatric oncology clinic at Wilmot Cancer Institute. It's standard process to screen for social support. And social support is not about number of people, it's about quality of relationship. So you might have 15 people in your network because you're talking to people at having a lot of people that you're talking to out in the world. But when you really count on someone might not be there either emotionally or tangibly. So we really need to understand that for especially older adults who rely on networks quite a bit. And we utilize that in our decision making for safety. So is this person safe to get treatment? If they're alone all the time and we're going to give them chemotherapy and they're going to fall or use medicines inappropriately, we have a pharmacist in our clinic who evaluates someone's safety for medicines. We will make decisions based on that and communicate that back to the patient and family members. So I think some of our research may design, as you said, more policies around this, but it is just good communication to involve network members.
Abby, what would you say to Maggie after that experience?
Yeah, I think there are definitely standards of practice at all of the cancer institutes to make sure patients are safe to receive treatment and to assess for social supports. I think the challenging part is there are some patients who don't want to share information.
Yeah.
And that's their right. They're protected by HIPAA. So I think it creates a really challenging dynamic if a patient is really resistant to share information with their family and they don't sign a release of information or anything. Medically, we legally cannot share medical information with them, and it can cause a really frustrating dynamic for the family members or loved ones who really care about this person and want to help, but the patient's a bit resistant. So again, social work can work with the patient to develop coping skills or confidence to be able to share the information. And also the medical team is always good at encouraging social supports and family supports as well.
Okay, Dr. Epstein.
This is a good example of where writing prescriptions is easy and coming to human understanding is difficult. It has not historically been part of physician training to really see the broader social context, at least when I went to medical school quite a while ago. Now it is. And so it's kind of implicit in the training that people say, okay, this is not a person in isolation. There's some simple questions that clinicians can ask, like, who's at home? Who do you talk to? What do they tell you? Sometimes a huge, long story will come out of that, but usually not. Usually you can kind of get a picture. And the other thing that I just wanted to mention is that we often think about family as these really close ties that we have, but sometimes the weak social ties are really important when you, so that cousin that you haven't spoken to in a while, but you know that they went through a similar kind of illness. You call them up and reconnect over this, or some friend of a friend who happens to be a doctor or something, whatever it is. People tend to utilize, and those could be actually really helpful. I feel really badly about the situation that you had because not everything can be preventable, but it sounds like some aspects of it could have been.
Yeah, Maggie, thank you for that phone call. And so, Dr. Mohile, when this study is done, are you still
We're still recruiting.
You're still
to the
recruiting.
Study, yeah.
Okay.
It's in the midst. It's actually we're towards the end of the first year of the study, so we haven't analyzed the data, but we're starting to collect really interesting data using an approach called mixed methods, where we're having patients fill out surveys, drawing maps of their social networks, but we're also doing interviews with them that Ron and Reza, our other MPI, developed that get deeply into the understanding of how patients make decisions with their networks. We're enrolling social networks also to get their perspective, like Maggie, who was a social network member for her father.
So tell me then on the other end of this, what do you hope? I mean, I know you don't know exactly what you're going to learn, but how do you imagine that it could be used to improve care?
Yeah, I think it will directly lead to us recognizing that what different characteristics of patients have in terms of their social support networks, and that will drive different kinds of intervention. So there may be patients that need social work or social support, but they don't want those people that they're relying on to be very close to them. They want the medical community to help them, or people with that kind of cancer, or their weaker ties, as Ron said, a cousin who may have gone through that experience. Other people may be deep into their family where they're working with their wife or living with their wife and their children, and it's just a discrete network. And in those, everyone has to have a shared understanding, or there's a lot of like you said, I need this information. I want you to do this. And the patient says, no, I don't want to do this, or I do want to do this. And getting them all to be in the right place will help everyone understand what the best thing to do for that patient is from the patient's perspective. And so we may need to have more family level counseling and therapy for that kind of situation. So it is one of the first studies, I think, to characterize this. I don't know of another study. Ron, I don't know.
You want to add to that? Yeah.
Mm-hmm.
Yeah, I think that families or social networks generally are an asset, and they're a resource that is underutilized, and so we're really kind of helping patients often realize what they have and who they have and how they can interact with people in their network who are willing and able to help them. And so we really focus on strengths in the social network. Clearly, there are some situations which there's a lot of conflict, but by naming the conflict, and that is the first step, and then you can actually bring parties together. I often find in these conversations, even people who seem miles apart in their perspectives, when they're sitting in a room together with a good facilitator, be it a social worker or a palliative care doctor or what have you, they come to some kind of shared understanding. They may not necessarily agree, but they can respect one another's choices. And so I think it's not only just discrete interventions, but it's a mentality that when you have one patient in a room, they are a representative of this wider network. And just that understanding on the part of clinicians, I think, generally will be helpful.
Yeah, Abby, maybe the way I would kind of sum up a lot of this conversation is, you hear Maggie's call, and she feels like more than a decade ago, her dad is in kind of isolation and frustration from her looking back, going like, this could have gone differently. There's not a perfect solution for that. To your point, some people are going to resist wanting to share information. But if there's an intentionality that says, hey, look, if you think isolation is going to help you, that's going to be up to you. But otherwise, isolation tends to not be good for people, especially now. So what can we do to give you a truly collaborative care approach? How do we make sure that we know if you've got this social network, this group that is with you that will help you? It seems like a very stressed medical system generally is at least being more intentional about making sure people aren't in isolation during these maybe the hardest diagnoses of their life. Is that a fair way to describe it?
Yeah, definitely. I think we've gotten very creative in ways to develop a social network for patients. If it's not their family, do you have any groups that you're a part of in the community, any religious community, neighbors, friends, anybody you know that's gone through something similar? A lot of the national organizations and local organizations that work with cancer have peer-to-peer programs. So we can connect somebody through Leukemia and Lymphoma Society, for example. They have a peer-to-peer program. You give some information about the patient. They can connect you with somebody maybe across the country who's going through something similar. We also have support groups. So being creative on creating a social network that might not be a typical family is really important.
Well, let me just read one more email. David in Ovid says he's referring to part of the conversation about MAID. He said, as someone with bladder cancer who does not want to live without my bladder, I have often said that I want a painless way to go when it comes to that. I do find the term suicidal ideation rather offensive. It's up to me to decide. I don't want the daily life of a plastic bag for a bladder, and it should be my right to end it all. That is David in Ovid. Everyone has their own right to a perspective, and David, we hear you there. I certainly wish you well, and I'm sorry to hear if you're struggling. I don't think anybody's using the term suicidal ideation to try to cause offense. I think it's just acknowledging, Dr. Epstein, that as we talk about MAID, there are it may be relevant to people who have expressed that desire in different ways, or to your point, apart from MAIDs being legal, sometimes people pursue their own means for this, right?
I have a few responses. First of all, I do resonate with that ability to choose. And in some countries, even if the bladder cancer could be cured, but you would have to have a bag to collect your urine, you still would have the right to end your life. In the U.S., that's not the case in any of the states that have made
nor
laws.
would it be here based on the way this law is written.
Yeah, and the New York law is fairly conservative in that regard.
Yeah.
So in New York, my understanding, unless the law is amended before it's signed by the governor, is that you need to have a terminal diagnosis with an estimate. Estimates are imperfect, of about 6 months or less. So there's that. The other...
and make it tight. We're going to hear the music in a second, so go ahead.
Okay, great. No, that's enough. So thanks.
Yeah. Are you sure? I didn't want to cut off the point there. I would listen to Dr. Epstein all day, and anybody who hasn't picked up his book, Attending, it is as relevant. I assume it's as relevant today. Dr. Mohile, you're nodding over
Yes, it is. It's a great book. And I think it's very relevant, and it has informed my practice in the clinic.
The book's called Attending: Medicine, Mindfulness, and Humanity. It is so important. And I just want to thank all three of our guests for a really important conversation. Abby Squicciarini, thank you for making time for us from the Lips and Cancer Institute. Thanks for being here.
Thank you.
Dr. Mohile, how do people get involved with your research going forward?
Oh, yeah, you can go to the Wilmot Cancer website. There is a clinical trial section. Just put in your platform, Wilmot Cancer Institute Clinical Trial section. We just achieved NCI designation. So we have lots of opportunities for participating in research. And if you feel like you're a good candidate for the research, any of the research on there, please call.
Thank you for being here, Dr. Mohile. Dr. Epstein, thank you very much.
Thank you.
And from all of us at Connections, thanks for listening. Thanks for watching.
This program is a production of WXXI Public Radio. The views expressed do not necessarily represent those of this station, its staff, management, or underwriters. The broadcast is meant for the private use of our audience. Any rebroadcast or use in another medium without expressed written consent of WXXI is strictly prohibited. Connections with Evan Dawson is available as a podcast. Just click on the Connections link at WXXInews.org.